Good morning, everyone. Nice to see a hall like this at 8:30 in the morning. It shows people are interested so much in iris repair. So let's look at this case, okay? Toric multifocal IOL. This was a VIP patient. Obviously, patient has had LASIK done before, went in for a toric multifocal IOL, went in for a refractive surprise. The surgeon then called me up and said, I'm having a problem, what do I do? Now understand, these patients are very fussy patients. Obviously, they want to be without glasses. So when I examined the patient, this was how the pentacam looked like, and I'll come to that more in detail. Important when you see pentacam, people look only at the astigmatism. Please look at the RMS HOA, higher order aberration. Look at that, it's 1.1. A normal person, please understand, will be 0.3. So I know this is a problem here. There are higher order aberrations here. LASIK was done 15 years back. My first problem was, there is not only an astigmatic problem, there is a spherical mistake also has happened. So I thought, listen, I have only one chance. This patient cannot come back again for surgery. Let me do an IOL exchange. So here you see I'm explanted the lens by putting it in the anterior chamber. I'm putting an IOL scaffold. So the lens which I'm going to replace it with, I put it inside. Now I'm very safe to cut the first IOL. Because my IOL is already there behind, I will not rupture the posterior capsule, and we published this in the JCRS previously. Anyway, coming back to this case, now what have I done now? I have solved my issue of spherical. But please understand, I have an astigmatic problem. My second problem is, remember, this patient had a multifocal IOL. That means he is very clear, he needs to see distance and near without glasses post-operatively. Now I put a monofocal for him, Virendra. I have not put a multifocal for him because I do not know, again I will have some higher order aberrations coming in my hand. So now what I am doing is, I am doing the Pupilloplasty. So take a straight needle, this simple goes inside, everybody has talked on it. Take a Proli needle, 9010 through cornea. From the other side, paracentesis. Paracentesis you need only on one side, 26 or 30 gauge, railroad the two. Once you do that, bring it out. Now remember the number 4. Pass it 4 times, and that is game, set and match. So you just pull. See, normally you do 3, 2, 2 or something like that. Every time you go in and pull out, you have a chance of hitting iris, chance of hitting IOL, chance of hitting endothelium. Here is just once, 4 times, remember. Now see, I am passing it from one end through the clear cornea. Now from the other end, I will now take this 26 or 30 gauge needle through the paracentesis, and the principle what I am doing is, we are going to make the pupil small. Once I made it pupil small, the peripheral rays get blocked. When the peripheral rays get blocked, the rays of light will go only through the center. Now look at this device which we have created called the holiday pinhole device. So understand one thing, when we started this procedure, I knew my knowledge on optics, I am telling you, is underground. Underground means deep down to the earth. I am that bad. So I knew I'll be in trouble. So I called up one man who is a guru of all, Jack Holiday. I told him straight, Jack, this is my concept, I'm doing this, but I tell you honestly, there is no way I'll take it to another level. And I'm not joking, since then till today, he is with us every time. So with him we designed this holiday pinhole device. So simple device is from Epsilon, I have no friend. Put it in front of the patient. Quresh, you have a patient who has astigmatism, put it in front of the patient. Ask him, does he like 0.5, 1, 1.5, 2? Whatever pupil he likes, make it. Understand all of you? Very simple device. Second thing, remember, if you see our latest issue with Priya and all we have done, and Jack Holiday, and I have to give full credit to Priya on all this peer review work and the SFT and the RFT which he has brought out also. But simple thing is, previously, I'll tell you honestly, I'm talking to you from heart right now, I used to always make pupils 1.5. And they are very good. I'm not joking. But then after some time, I started seeing these patients post-operatively. I started asking myself, can I make them better? They'll be 6'12", very good. I'm very happy. From counting finger 1 meter to 6'12", the patient is jumping. Can I make him 6'6"? Then I began to understand, if you have higher order aberrations higher, the pupil will have to come smaller. Matlab, I said normal is 0.3. So let's say he has a 3 HOA. I'll make 1.5. And I've checked this in our peer review paper. We have checked this. Basically, it'll happen. Let's say he has a 13 HOA, highest. He will go to 1 millimeter pupil. And you can check with him. He asks for 1 millimeter, automatically bolega, bhai, give me this, I like this. So automatically make the pupil 1 millimeter pupil. So let's make this short because we don't have time now. I'm making this smaller and smaller. Now one more trick I tell all of you, okay, which we started now and I'll just show it to you soon. Look at the endelevator from outside. The key issue is one size. You have to be bang on track. But the second biggest issue is the location. Your Purkinje image P1 has to be bang centered. Okay? So look, always keep a vitrectomy probe. All your phaco machines have vitrectomy probes. I use a posterior vitrectomy constellation, but you don't need that. All your phaco machines will have it. But look at the Purkinje image now. It's bang centered. You see that? Now, if you want to make it look aesthetic, a trick which I learned now, I've not done it at the disc space that much, is switch off the microscope light and use only the endoilluminator for doing the small pupillectomy. You'll get a class thing, and I'll try to see if I can show it to you also. But look at this patient here. Pre-op 636, post-op 66 N6. Because what you have done in this case is basically, you made it a pinhole, no doubt. He can see distance and near without glasses. So his multifocal problem is solved. Now I'll show you another interesting case, okay? I tell you what, to be honest with you people, we are doing a lot of keratoplasties in our center, about 120 a month, which is one of the highest globally if you ask. But now I started doing cases like these, which anyone will think of, let's do straight PK. I'm saying no. Can we manage them without keratoplasties? Now look at this case, okay? I've got 5 minutes left. So look at this patient. This patient came to me from Bangladesh. Look at the case, 109 HOA. Can you believe it? I asked him, what is the HOA before I operated? They said 109. I said, are you joking? I never seen a patient with 109 HOA. Remember, normal is 0.3, okay? 109, the highest till now, before this case I had operated was a 13 HOA. I said, 109. Man, that's crazy. So now look at the astigmatism, about 48 abdominals of astigmatism, okay? So I said, listen, the surgeon who had operated had messed up the corneal suturing badly. So I thought, let me remove it. There is a traumatic cataract also present there. So now what I'm doing is, I'm doing a phaco, and now you see the fastest phaco in the world. Just watch. It happened so fast, I had to see it on slow motion later on while I was editing my video. Look at that. I've done my hydrodissection. Now I'm going for my phaco, and you'll see that in a second, and gone. You know what happened? It came out of the wound. My wound opened up. Oh, my heart sank. Pop. Okay, I said, patient has come all the way, referred to me from Bangladesh. Man, I thought make this patient all right. So I said, okay, now nucleus has come out faster than I can imagine. Let me suture it up. Still leaking like crazy. I have an upper burner this time. Okay, my heart is sinking even more, by the way. I'm trying to avoid PK. You see how dumb I am. Thinking of the craziest things. Anyway, I put the 3-piece IOL inside. I always choose 3-piece IOL because suddenly I go into complication, I can convert to glued IOL. Okay? So in such cases, you'll be better off with a 3-piece IOL. At least for me, I feel it's always better off. Now anyway, I'm doing my 4th row pupiloplasty. 3 minutes left, but let's understand how to close up this case. Now important is, please understand, if this car is off-centered from the cornea center, very easy for me to do. But here you notice it is really near the center. Understand my problem here, that's where the challenge I'm facing. So now, when I will do my pinhole, I have to keep it exactly bang on track. I have to miss the scar, and I have to see my Purkinje image also bang on track. Now I'm just saying, can I do it or not? Worst comes to us, if I didn't work, I knew I'm making a pinhole, later on I'll do a PK. And my pinhole will anyway solve the problems. But now look, I'm using my endoilluminator, look at it, using the vitrectomy probe, I'm just making that slowly and carefully so that my Purkinje image there is just missing it. Now, in the night, I just, look, this is with the microscope light switched off. Okay, I'm using only an endoilluminator. Now in the night, I didn't sleep. I was just hoping and praying this patient will see the next day. Post-operative, day 1, 6/12. Look at that. Now you look, I'll tell you something better what happened, okay? Look at this. The HOA, I had shown this to Jack Holiday, and look at my HOA from 109, within post-op day 3 went to 5. Because I had resutured the cornea properly, it went to 5, and the patient went to 6, N8, post-op day 3. So I just thought I'll show you this case, and let me see if I can just show you one thing more interesting. I'll show you another interesting, just a photograph because we don't have time. Okay, but it's important for you all to see this. This was a post-DALC. Look at a picture on the top. Done by us only post-DALC, but there's a scarring on the cornea. Okay? I said, listen, I'm not going to redo a DALC. I did a pinhole. See a pinhole? This is without the microscope light. This is how coaxial. Look at a 1 week post-op, 6, N6 without glasses. What is my message? Want all of you, please move to pinhole. You see a lot of advantages. You will be in the learning curve. Second, bigger, when you master the game a bit, you will understand corneal scars, these cases which you normally would have sent for PK or something, you can manage very well with pinhole and make them all right. Thank you very much, ladies and gentlemen. Any questions?